For the next session, I would like to invite Dr. Umesh Gupta, consultant physician and diabetologist at Manipal Hospital, Bengaluru, and Dr. R.S. Venkateslu, consultant interventional cardiologist at Sparsh Hospital, Bengaluru. We welcome you, doctors.
We'll call upon Dr. Ranjan Shetty, Senior Interventional Cardiologist from Sparsh Group of Hospitals, and is a Medical Director in Sparsh Group of Hospitals, for the CT coronary angiogram, the newer perspective.
Thank you. Good evening. It's nice to see, nice to be among friends. Thank you, Dr. Manohar, for inviting me. I didn't know there was such a beautiful hall here in this. We used to walk around this place most of the time. The topic today is on coronary CT angio. So forever, the biggest threat in human history or in heart disease is to predict tomorrow's heart attack. People come today, we check, we get ECG done, we get echo done. It's all normal, but the patient could still have heart attack tomorrow or in times to come. So always the question for us, for cardiologists, and I'm sure doctor will agree with me, that how do we pick up? There's a lot of fear, a lot of anxiety. There are a lot of decisions we need to take. How do we sort it? So now we think there could be an answer to this question, but answer is not very clear. And we feel that answer is in coronary CT angio. Now, is it for everybody, or what does it mean to have some calcium? What does it mean to have some block? That's what we'll discuss in whatever time we have. So it is non-invasive. Why is that CT took such a long time to develop? If you look at many other diseases. Initially, conventional angio was the answer for all angiography. Whenever you wanted to look at the artery and sometimes you wanted to look at the vein, only thing you could do is take a shot in cath lab. And some of these were done by cardiologist Dr. Sanjay Rao knows that people used to do a lot of these angios, peripheral angio, but most of them with the advent of CT is been replaced by CT angio. But when it came to heart, it was a little difficult for CT to overtake. It took some time because CT needs this to be very stationary. It's like taking a photograph of a person who is running. So there is a lot of artifact when the structure is in constant movement. So it took some time. So minimum slice what we need is 64 and above. It can't be below. It has to be ECG gated. Most CTs even now require a lower heart rate. If the heart rate is 90, 100, they can't take the proper image. But technology is fast advancing. There is AI which has come. There are dual source. There are many ways which this has been overcome. Now most CTs can directly take your CT angio. So where does it stand in the current era, or where conventional angio is also present? You have CT angio, probably you have calcium score. So there are multiple things which have come. Where does it stand? So in detecting heart disease, now blocks, if you look at blocks, CT is 95% predictive. So if you look at TMT, what is the predictive value of TMT picking up a block? Block means significant block, more than 70% block. So TMT can pick up to 70% or 77%. It overdiagnoses 1/3 cases, it misses 1/3 cases. So practically the predictive value of TMT is as good as tossing a coin. It's 50-50. But then we take a lot of things in consideration to make that intelligent decision where this TMT is likely to be positive or likely to be negative. So TMT does not have huge role. I have had patients, and I'm sure others will also agree, one person who came to me, did a beautiful TMT, completely normal, it was negative, went home in a rickshaw, had a heart attack and came back in the same rickshaw back. So that's the predictive value of TMT. You can't predict that days, you can't predict tomorrow. So when it comes to CT, it may not tell tomorrow there will be a heart attack, but it can pick up disease. It can tell us there are blocks. Now these blocks could be more than 70, more than 50, or it could be a minor block. But what we know that even minor blocks can lead to heart attack. That's the problem. That's the paradox. That's why people run marathon, then collapse. They're able to finish marathon because the blocks were less than 50, but the stress of marathon or stress of extreme exercise, what you keep hearing about celebrities collapsing, that's because they were the minor blocks, which now something happened to those minor blocks, we call it plaque rupture, and that 10% block now suddenly became 100% because there is clot plus plaque together and the artery is completely occluded. So having any block is bad. And having any block needs treatment. They don't need stent, but they need treatment. They need medicines like statin, they need aspirin, and that brings a lot of value. This is where the CT is come into picture, and this is where it helps us to make some wise choice. Now, all of you know it's non-invasive, it's the CT scan. The difference is there is still contrast which is given, and generally it is given by a little large bore needle. So 16 French, 18 French later in one of the prominent vein is where it is put and the CT is done. Typical CT, but needs to be minimum 64 slice, maybe higher. Now there are even 512 slice CTs which are available. And with AI, the technology, AI also modifies the post imaging, so it is better. Now let's discuss about two risks here. One is radiation. How much is the radiation of a CT? The current CT, the radiation is 3 to 4 millisieverts. Now the background radiation, what we all receive is also 3 to 4. It said that one Atlantic flight, from here, you go to US and come back, you are exposed to around 4 millisieverts radiation. So if you do a CT that year, don't go to US. So the radiation could be managed. And with Trump, I'm sure it is difficult to go to US too. So you could, whoever needs can get the CT done. Second is the contrast. Nowadays, the contrast which is used is the 4th generation contrast. And it's quite safe. Contrast nephropathy is not that common. But creatinine more than 1.5, I think CT should not be done. Calcium score can be done, CT should not be done. So these are the two risks of CT. Otherwise, there is no major risk which is there with CT. Typically, 3 to 4 hours fasting, breath holding has to be done, and it's a simple scan. ECG gating is must because they only then they get good images to analyze. Now let's discuss of two things. What does CT calcium score mean? Now this can be done in most machines. You don't even need 64 slice. Anything more than 16 slice with the proper software, you can get a calcium score. Now, if somebody has a CT calcium, 1, 10, 100, 400, what does it mean? So I think 2-3 things we need to understand. Calcium is, this is how it looks in the picture. It's very easy to pick up. A heart rate up to 100 is okay, and absolutely no fasting, no IV line needed. So any patient who comes to us, sometime instead of TMT nowadays, we get a calcium score because it gives a better information. What we need to understand is this calcium is not the calcium which you eat. It has nothing to do with vitamin D or any other metabolism. Here, calcium means block. It's a surrogate marker for block. So if anybody has calcium, whether it is 1 or whether it is 1000, they practically mean the same. There is no cutoff. People want 100, 400, more than 400, less than. It doesn't mean that. We see all kind of combination. So calcium here is a modified cholesterol, which is a plaque, and that plaque has slightly been hardened. That's the calcium you see. It is a modified cholesterol. It's a surrogate marker for block. So anybody with calcium needs two things. One, they don't have to worry about eating calcium or food. Second, they need to take statin. They also need to take aspirin. Now that going by that 100, 200 does not work. And CT calcium score is a very easy test. So at Sparsh, what we did is that as a part of employee health check, we actually got the calcium score done for everybody. Because you see this young people dying of heart attack is common everywhere. It is universal. It has nothing to do with COVID or its vaccine. We have seen it before COVID, we are seeing it now. So it's definitely there. How do we pick up? Do a calcium score because it is very simple. And if there is a calcium, treat them. You don't have to do angiogram for them. Treat them with aspirin, statin. Whatever LDL they have is high for them because it has reacted. It has stuck. It is some, calcium, once it gets stuck to the artery, it starts growing. So you need to arrest the growth by giving statin and aspirin, and most of us now target post-LDL to be 55. Now, is calcium enough, or should we do a CT angio? That's the next question. Now, calcium, just a calcium score picks up to 90% of the people with block. So if there are 100 in the room, 90 of them you can pick easily. And just calcium score is enough. But you still miss that 10% of people who have soft plaque. A plaque which is not calcified, but it is more likely to rupture. And we see this in younger people, we see this with diabetic. So when I was in Manipal, Dr. Sanjeev, we used to get a lot of CT angio done. We analyzed our data there, and we understood that 10% of people we still miss. So they are the ones who need CT angio. So we don't know who is in that 10% or who is in 90%. So what we recommend for most people is, if they are worried, I'll tell you the indication later, for them to get a CT angiogram done. And if somebody's CT angio is normal means it has to be 0 calcium, 0 block, the next 5-year heart attack risk is negligible. That's the advantage of this test, We do it for people who come again and again with chest pain, so-called cardioneurotic, who end up coming to emergency, going back, instead of, there's no way you can tell them nothing will happen, because we don't know whether something will happen or no. It's better to do a CT angio, and if it is normal, 5 years they don't have to come, and most of them get so reassured that they don't come. Now they know that they don't have to run. Otherwise, it's a real fear. It's not that they're acting. There is a fear and there is a possibility. So we need to be very sure to convince them that it is okay. What we do after 5 years, typically the blocks come between 4 years and 5 years. So at that point, you do one more CT. If the second CT is normal, the predictive value goes to 15 years. That means with 2 CTs spread across 5 years, but shouldn't be very young when you start. You can't do it for a 23-year-old. Preferably the first one is between 35 to 40 years of age, and second one is around 45 to 50. You do the second one, the predictive value is 15 years. So you can predict 20 years of heart health using 2 CT scans. Should we do it for everybody? Should government do it for everybody? That's the question which we should answer. Obviously the answer is no, you can't do it for everybody. So who are the people whom we do CT angio? Anybody with the risk factor. That means if there is a family member who has had a heart attack, anybody, young cousins, direct relatives, then we do it 10 years before the family member. If they had at 45, we do it at 35. If they had at 55, we do it by 45. We also do it for people who are asymptomatic, but their treadmill test is positive. We know so-called false positive. Instead of doing angio, we could do a CT angio. Who else we do? Borderline cholesterol. Cholesterol is a number which will keep varying. Each lab will give different number, and people get very panicked and they come and ask us, should we take statin or no? And if a cardiologist prescribes statin, it's for life. There's nothing called 3-month statin, 4-month statin. Nobody will dare to stop. So instead of starting so-called healthy people, it's not a bad idea if they have borderline high. See, 190 is high. LDL done by direct technique, and if it is above 190, it's high. Such people anyway need statin. But 160 to 190 is borderline high. That's the number. If it's less than 130, we can forget it. If they're not diabetic, you don't need anything. For diabetics above 40, which is probably the core of this conference, the LDL target is 70. So in diabetic above 40, it has to be less than 70. Again, there is no use doing CT because most diabetic anyway need statin. So it's for those non-diabetic whose cholesterol now remains constantly borderline high. Instead of starting some tablet for life and risking them, it's a good idea to do a CT angio. If it is clean, don't start any statin, you could live. So these would be 4-5 indications. We also do it for people who, for a low risk patients who come to emergency with chest pain. We call it unstable angina. Earlier we used to do treadmill for them, but we know treadmill is not that predictive. Now most of these patients, we do a CT and then send them home. So we are also more reassured, we are also correct when we do it. And the imaging is becoming more and more good, beautiful as we speak. The contrast level is coming down. Now from 80, it has already come down to 60. The radiation is decreasing. AI is helping radiologists to report. So lot of good. It's also useful in picking up anomalous coronary. You know, people do have anomalous coronary. Sometimes it's between two great artery and it could be dangerous. CT is something which could help. So soon there will be a day when me and Dr. Venkateshlu here may not have to do any diagnostic angio, because CT would mostly take over that space. We will be involved in more intervention and therapeutic angio. I'm very sure the time, it's not there today. Today we still have some technical issues, technical challenges, reporting challenges with CT, but soon all those will be overcome and it will be a big part of what we do. What are the limitation? If the calcium is more than 400, CT now has blooming effect. Hence, it cannot look at the lesion. They will end up getting a conventional angio. So, it's a good idea to do calcium score for many people and decide. Sometimes smaller stents they can't see, larger stent it can still be seen. We discussed about heart rate, we discussed about small branches. Still, there are stitch artifacts, there are radiation risk, and all that definitely exists. One area where CT is very useful is post-CABG grafts, because motion artifacts are less. So if somebody has undergone CABG, 4 grafts are put. Earlier what we used to do is we used to take them for angio, then it used to be a nightmare to search all those grafts, and there is 1% risk of stroke in them when you meddle. So now what we do is we do a CT angio, find out how many grafts are there and whether they are patent. Then we do a conventional angio to give the information of the native arteries. So together it's easy for us to plan the treatment. So CT angio now is probably a need of ours. Most people might need 1 or 2 CT in their lifetime. It's complementary to conventional angio. The indications are completely different. When you are high risk, when the risk is high, when you need to do it is conventional angio. For so-called moderate to low risk, who want to know their heart disease, where we need to plan medication, it's been CT angio now. So thank you. Happy to take any questions.
It was an elaborative and excellent presentation. So nobody can match this presentation. I believe in the CT coronary angiogram, he made us to understand, and he has given what exactly is required. So any questions? And even now with the advent of AI, we are doing fractional flow reserve. It is available in India now, wherein we can co-register the same thing with the angiogram and we can exactly pinpoint which is the lesion which has to be tackled. So the advancement is so high, not only CT, it is the AI-assisted fractional flow reserve is coming to India. It has been there in some centers, I believe.
Yes. Only thing is it's been little more, that technology of AI has been costing around $1,000.
Yeah.
Which in, it's almost ₹1,00,000. Most angioplasties are done in that this one. But it's going to change. It's the space to look out to. Yeah.
And even with CTOs, we've been using CT scan as a tool to assist to find the calcium, length of calcium. It is definitely helpful. And he clearly pointed out about post-CABG patients. It is painful to do a graft study. So do a CT scan and then attempt for angioplasty or revascularization for this patient.
Absolutely.
So one question. Is there any correlation between the calcium score and the percentage of block?
So the simple answer is no. There is absolutely no correlation. So we have seen people with 1,000 calcium but minimal block. I've seen with 0 also having block, as we discussed. 37 could have 90% block. There is no correlation. But if you have more calcium, you are having more plaque. Hence, the overall chance of finding a significant CAD increases. But there is no direct match. So even if the calcium is 1 or 1,000, the treatment is still statin and aspirin. More important than doing an angio. That's the key, because the natural history changes with them. Angioplasty doesn't change the natural history to that extent.
Thank you.
Good evening, sir. Good evening, sir. So my question for you, sir. score above, anything above 0, we start with aspirin and statin.
Yes, yes.
Number doesn't matter.
Number
you just
doesn't
put him
matter.
on treatment.
Yes. So you need aspirin statin with that score. Then you need to assess them. If they're asymptomatic, that is enough. They don't need. If there is any symptom or borderline symptom, sometimes we come back and do a treadmill for them to assess their effort tolerance. If there is a dyspnea or you're not sure, you may have to do conventional angio. Any number, it doesn't correlate at all.
So continue lifelong.
Yes, it's for life and the target LDL is 55. 55.
55.
55 after that. So when you keep LDL close to HDL, we believe new plaques don't come and whatever plaque you have could regress. But the funny thing also happens as a step on. Imagine there is somebody whose calcium score is 100 and now you have started statin. You do 1 year later repeat calcium score, it actually increases, it doesn't decrease because the plaques now start getting hardened and the calcium score increases. So also telling you that calcium score doesn't mean heart attack. It just means blocks which are there. On statin, if there is a higher calcium score, it is not necessarily harmful. Yes, stabler plaque, hence more safer.
Thanks.
So, in that case, CT angio would be more sense than doing a calcium scoring.
Yes.
Because calcium can deposit on the outside of the lumen,
Correct.
whether extra luminar rather than intraluminar.
So there are 2-3 ways to answer this. The first question is calcium means block, but not percentage of block. So when somebody has calcium, it could be 10%, it could be 90%. Now, should we know whether it is 90 or 10? So if you look at the population, it doesn't matter. 10, 90, both will live as much as they are supposed to live. Stent or no stent will not change the natural history. Both 10 and 90 need aspirin. Both 10 and 90 need statin. How does 90 differ from 10? 90 could be symptomatic. They might have dyspnea. Such a patient, if you do angio and put a stent, they do better. But stent for a stable heart disease does not prolong longevity. Hence, it is only symptom relief. So it's very important to pick up the block and start aspirin and statin. That's the first level.
So, does it make sense to say that there are chances for having a high calcium score in older people than younger people? Because youngsters, although there may be some plaque deposition, but it may not be converted into a heart plaque or a calcium.
Absolutely, you are right. That's why we are worried about just calcium score in younger person. If there is somebody is 40 and is diabetic, calcium comes 0, I'm still not sure whether there are blocks or no block. I'm more worried. Older people will have more block. Having said that, you know, at 75, like just yesterday, 2 of the patients had 0 calcium, even at 75. So it's just possible to have no blocks at any age too.
So doesn't it make sense to do straight away CT angiogram rather than asking for a calcium
Yes.
scoring?
So what is recommended for whenever you want to predict, whenever you want to tell nothing will happen to you in next 5 years, is CT angio with calcium score. Because all CT angio come with calcium score. But if somebody is in hurry and you are deciding about statin and they are little older, just a calcium score is okay. Because the calcium score is done in 10 minutes. No radiation, no this one, no fasting. So it's a good screening tool. Instead of doing a TMT, it's a good idea to do a calcium score. Have a specific indication for CT angio.
Thank you, sir.
Thank
Thank
you so
you,
much,
thank you.
doctors. I would request the chairpersons and speaker to move to the selfie area for the group photo.